Good afternoon, everyone. On behalf of HiTech, we welcome all the participants for today's National Distance Learning Seminar Series. Today's presenter is Dr. Manish Bamrotiya, and he is going to present on Referral Linkages. Dr. Manish Bamrotiya is currently working as Program Officer for ART with Care Support Treatment Division at NACO. He obtained his MBBS from BJ Medical College, Ahmedabad, and he completed his fellowship in HIV medicine from School of Tropical Medicine, Kolkata. He worked as a medical officer at ART Center, Megasena, Gujarat for 3 years at Infectious Disease and Tropical Medicine Clinic. And also he worked as a regional coordinator with NACO for Rajasthan and Bihar. I thank Dr. Manish Bamrotiya to accept the invitation. Now I'm handing over to him to take over the session. Thank you.
Thank you, Sudarshan. Good afternoon, everyone. First of all, I'd like to wish all of you, all of the ART centers and the staff a very happy new year and best wishes for the upcoming festivals of Makar Sankranti, Pongal and Lodi. Moving forward, today's session we will be discussing referral and linkages. So you all know it is a very important programmatic issue. Now to start with, I'll like to know from you, like there was New Year wishes sent from Team CST from Dr. Rivari on 1st Jan 2016. I hope all of the ART center has read this in detail, and I want to know from you what was the slogan that was given by Dr. Rivari sir on this new year. So if anyone can tell me what was that slogan, whether you have received that email or not, and what was that particular slogan which was given on this new year to all the ART centers. So any center can recollect. I'll wait for a few minutes to, I think some of you are just joining, and so there was a New Year wish from Team CST sent from Dr. Baby Rivari's mail on 1st, and there was a particular slogan in Hindi which was an important part of that wish. Can anyone recollect that slogan? So I don't see any responses to this. Maybe you have not read, or maybe you have not received that mail. So first of all, I'll request all the ART center to check your inbox. There will be a mail. Please go through what have been sent to you as a New Year wishes from the National CST team. Yes, so very good ART Shillong. It was koi PLHIV chhoot na jaye, link toot na jaye. Very good. So this we expect from all of the ART center. Then whenever we send some messages, at least you should go through it and read it. So I am sure many of the others, very good. Yes. So there are few ART centers who can recollect it very well. So basically it focused on making all efforts to detect all those who are infected with HIV. So detect them earlier, provide treatment to all those are eligible as per our national guidelines, treat them properly. Properly means correct dose, correct time, correct diagnosis of OI, correct OI medicine, and correct treatment regimen as well. Retaining them in care is almost very important, and then regular monitoring. So you know, it is a care continuum starting from diagnosis till retaining them. It is a continuum, and obviously many of you have already said slogan was koi PLHIV chhoot na jaye, ye chain toot na jaye. So that the very message behind that was like complete HIV program should work as a team, and we should ensure referrals and linkages, because it is not possible ki we give all the services at one place. So you will be having certain services at one place, and you will require to refer patients to other services as well for various reasons that we will discuss later on. So it is very important for us to refer patients and see that patient reaches to the another service level. So what is referral, what is linkage, and what is difference between two? I want to know it from ART centers, because you are referring so many patients, or ICTCs are referring to you, you are referring within your divisions to other facilities. So what you understand by referral, what do you understand by linkage, and is there any difference between two, or both are same terminology? So I want from few of the ART centers to answer that, and I'll wait for the answer till someone answers it. So the question is, what is referral, what is linkage, and is there any difference between the two? Anyone? I hope someone are typing their answers. I'll repeat my questions again. Yes. So referral between two facilities. Okay. Referral means seeking services from other facilities. Very good. Yes. So referral means somewhat like this. And what is the linkage? Anyone? So few of the ART centers has very well said this. Referral means seeking services from other facilities. You are sending that particular patient for some other facility at for some other services at some different facility. So that is, yes. And linkage means send to, means to link the patient in other LAC. No, it does not mean that. We are just, don't limit your thinking. Be wide in thinking. Have a broad mind. So think clearly. So linkage is coordination between the facilities. Yes, somewhat. Yes. Reaching to referral point and receive service. Yes, very good. So that is what is. So that is the difference. So linkage means, referral means you are telling patients or you are advising patient to go to a facility, while linkage means confirming that the patient reaches that facility is the linkage. So yes, referral for medical facility, linkage to PLHMA. So those are the terms we use as for our programmatic indicators. For broadly, linkage means, referring means sending that patient to particular facility, and linkage means confirming that patient reached there. Very good. So definition is this: referral and linkage services. It encompasses a spectrum of service ranging. It can be a range of service, like simple act of providing information, like many times you say, na, go there, visit there, do sputum examination there, or go to this facility and do that particular test. So this is a simple act of providing information. This can be a referral as well, but it can range up to, so there are various processes in between, and it can range up to like confirming the client's engagement in service, that wherever you are telling that patient to go, so confirming that patient have reached there and availed at least one service, that is linkage. Now, can anyone tell me what is care continuum model or what is comprehensive service delivery, and how linkage is important in that? I have hinted that already, but I want to know from ART centers what is their opinion regarding comprehensive service delivery or care continuum. Nowadays we are talking lots about this continuum, care of continuum, retention cascade, comprehensive service delivery. So what at ART center, what you understand by this? So I'll wait for someone to answer it. Yeah, so you have to tell me what you understand by comprehensive service delivery, by care continuum model, or by retention cascade. Okay, so Udaipur is telling after registration, preventive and promotive curative services. Yes, sort of this. Yes, very good. anyone else, any other center, yes, provide all necessary service under one roof. May not be possible under one roof, but yes, I'll take the first part, that is providing all necessary services. It may not be under one roof, and that is why you will require referrals and linkages. You may not have all the diagnostics of like diagnostic facilities for other opportunistic infections or preventive facilities for HRGs at ART centers, but you definitely have facilities whose core competency is that, and you need to referral. So continuum of care is, since the diagnosis or even for HRGs high risk group, from the time of identification of them, preventing HIV, then if they are HIV positive, diagnosing HIV, and if diagnosed positive, linking to care, availing care, retaining in care, all these is included in care continuum model and comprehensive service delivery. So it may, as I explained earlier, it may not be possible to provide all those facilities in the single window under one roof. That's why you have various facilities across within institute or maybe outside the institute as well. So that's why where you need referrals and linkages. And as we have already discussed, linkages is extended to a further step, which includes ensuring and verifying clients' engagement with the service, and the final outcome of referral need to be verified in terms of specific outcomes and indicators. So this is very important. This is why this particular session has been kept. So like many a times we have seen, almost you all have felt many a times we tell our patient to go there, visit that facility or avail these services, and we never bother whether that client has actually reached there or no, so or not. So that documentation and confirmation of engagement of client in the referred services is very important, and that is what we want. Like referrals is just a stage. Our job does not end at referring some patient. Our job is to confirm the linkages of that particular patient to that particular services. So why referral and linkages are important? Again, I have given some hints, but I wanted to hear from ART centers. What do you think? Why we are talking about referrals and linkages? In your review meeting also you have seen most of us will talk about how many have been referred, how many have been linked to RNTCP, how many linked to CAC, how many linked back to ART center, what is ICTC to ART linkages, and so many things. So why this is important? Why we keep asking these things from you? So there is one answer, key referral and linkages is very important to client and ADPs. Yes, it is very important. Yes, for HIV care and treatment, for continuum for treatment, what is our ultimate aim in providing ART or HIV care or having so much of facilities? What is our ultimate aim? Yes, so very good. Again, Udaipur, very good. It is quality life for PLHIV, decrease mortality, decrease transmission. All this is our, yes, less mortality, and so all you know very well all these things. And this is why referral and linkages are important. We want to, because you all know, yes, client needs to get all services, and all services are not available in one center, so referral is required and linkage is required to ensure that whatever referral you are doing is successful or not. So ultimate aim is viral suppression in PLHIV, decreasing mortality, and so there are stages: diagnosis, treatment, retention, prevention. All these are stages, and every patient goes through that stages, and it is very important to ensure that from one stage patient reaches to other stage, and that is why referrals and linkages are very important. So this is what we have discussed. Okay, comprehensive HIV care that aims to provide effective prevention interventions to those at risk and quality life to PLHIV. So there can be wide spectrum of need that the PLHIV might have, and that can be met through effective linkages to various services. So you all know it, PLHIVs may have, it is just not the one need, they just don't need ART, there can be other services as well. Yes, Motihari, very good. Clients requires other important facilities as well. So to maintain continuum of care, linkages are crucial to ensure retention in various stages which may be located at different facilities. So that is what we are discussing. Now, can anyone summarize like what are the principal needs of a PLHIV, like say at diagnosis? What can be like patient is, that is the reason why I have called many of the ICTC counselors as well, and it is very good that many of the ICTC counselors are also present. So what are the basic needs of a PLHIV regarding referral? Because at ICTC they will provide only, they will provide not only, they will provide the counseling services, they will provide testing facilities, but it is a one-time interaction or one or two-time interaction. And what other needs can be there for PLHIV at ICTC or say for ART, at first visit at ART? What are the various needs or what other needs you can think of? Just let me know what are. Yes, so there is diagnosis, registration, testing, moral support. Yes, very good. Yes, as sir is saying, pregnancy can be a important factor. Anyone else want to? Yes, social schemes. Yes, very good. Social schemes can be there. RNTCP, yes. So basically it is to include a broader term, diagnosis of opportunistic infections. Yes, family details, very good. You, most of the ART centers and CSCs are well aware of all these things because you know, because you are doing it on daily basis. I'm sure you are, yes, very good. Psychological support, because at diagnosis, patient will be like emotionally challenged and all things. Yes, baseline investigations and many more. So you agree, like PLHIV, it is not just ART, it is a complete scope or complete spectrum of services that may be required at time of diagnosis or at time of first visit or during subsequent visits as well. Okay, very good. So now, well, briefly, I'm sure most of the counselors know these things, but again, I want to re-emphasize this, कि whenever you are referring a patient, whether an ICTC counselor or an ART counselor or a CSC counselor or outreach worker or anyone, whenever you are referring patient, please keep these 6 points clear in your mind. First is, you have to assess the need. Like you all very well enumerated most of the needs that PLHIV can have, but it is not that every PLHIV will have all particular patient based on his or her psychological condition, his social condition, his family issues, his health issues, his behavior, his risk factor, all these things you need to assess, and then you will come to know ki what are the facilities that I am not able to give to this particular patient and he will require a help of another facility. So this is how you assess the need. Then there can be prioritization. So can someone tell me ki what can be the priority? How you can decide on priority? Like PLHIV will require some psychosocial effect, OIs, social beneficiary schemes, ART, much more. So how will you prioritize? What should be the first thing? Because it is very clear, you can't send one patient to all facilities simultaneously. You have to prioritize the needs. You will assess the needs. You will get to know ki, okay, this patient have this much needs, and how you are going to prioritize. Please, anyone can tell me. Yes, so priority diagnose OIs can be depending if patient is critically ill, then the priority will be opportunistic infections. Yes, very good. For pregnant lady, the priority can be something different. If a healthy pregnant lady, HIV positive, her priority can be different. A critically ill patient, his priority can be different. A high risk group patient coming to you, his priority can be different. So that you need to prioritize, that there cannot be single guideline to prioritize or assess. It is the counselor's ability or healthcare providers ability or ART staff's efficiency to identify the required referrals, or rather than ART, it is the ICTC's efficiency to identify and prioritize the uh, uh, steps for referrals and linkages. Then you need to plan. Please, whenever I go to any lectures or any interactions or any review, I always tell that what is, whenever we are talking about EID, and you all have felt that key patient, it is very difficult to follow exposed child till 18 months of testing. It is very difficult to convince that mother to come 3 times or 4 times for testing. So what is the reason? Can anyone tell where we are lagging this? How can this be improved? So whenever you are telling some patient, go there, patient didn't turn up there, patient don't follow us with so all the procedures. What can be the reason? Can anyone tell me? Yes, very good. Kasargod, excellent communication gap. Yes, I have seen very few ART centers to accept that. Yes, Udaipur need to counsel about the life of upcoming. So we lack planning. We just tell them ki you come to this particular day, we will test you and will give you result. Then that poor lady comes with the child, and then you tell ki still the result is not final, we need to retest the baby after this many months. Again she'll come, then you again tell if negative, now we need to do a third testing. So we lack in planning. So you need to involve patient in planning the referral. For example, you are sending patients to RNTCP for sputum examination. How many of your patients go to nearest sputum examination? That depends on the ability of staff nurse to counsel the patient and plan with the patient. Okay, so it is very important you plan, you explain everything, how to collect sputum. This you can expect this. If you tell all these things to patient, you plan properly, and it is not you plan, you assist patient in planning that particular referral. That is very important. Then is facilitation. We'll talk in detail about facilitation. Can be like you just give if appointment is required. For example, I'll tell you how facilitation. Once I visited ART center Himmat Nagar in Gujarat, and they had very good practices of, they provide that sputum collection yes, for RNTCP referral. So this type of innovations can be done. So these are facilitating. So you can give appointment, you can try to help, you can help patient and provide getting appointments, you can help in some sort of that can be easier for him to go there. Okay, or it can be assisted for, and I always request all the counselors of ICTC who have a ART center in the same institute, please try an accompanied referral. You can have an outreach worker, or like it is not ki daily you can get like many positive, you will be getting very few, and you have a ART center in the same building or same institute, please try to facilitate by accompanying that patient. Okay, so ART Bodhihari is saying we provide them different problems related health issues, TB, Kala-Azar. Yes, very good. That is, yes, we do referrals, and we provide many services as well. Then next is very important, follow-up. This is extremely important thing. because I have seen, and it is it is very unfortunate and disheartening also. Many a times you see we have referred that particular patient, coughing patient, to DMC for sputum, and then we are forgetting about it. We are not following it up, and 1 month later patient again's come, and then you will be knowing ki, okay, patient didn't go for that particular sputum test, and patient's symptoms may get worsened. So this kind of follow-up is required. Again, one example is your transfer outs. Again, that is a type of referral. How many of you are following your transferred out patient to ensure that whether they have registered at another ART center or not? Very few. I always get such mails from various ART center that I transferred this patient 2 months back, and now patient returned to me without going to that particular central. What to do, what can I do, where to put that patient in monthly report, what to do, what to write in ART register, whether to continue on same number or whether to give a new number. So please, that is not important. Important is this: why this happened, why you referred one patient, that patient didn't took any medicine for 3-4 months and then again returned to you without going anywhere. This should not happen. There was 1 month, 2 month, 3 month time where this patient could have been followed up, and believe me, nationally we have many such kind of patients. So it is like this follow up and documentation is very important. Okay, so we'll move forward. So we have discussed it already, so I'll go quickly over this. So it is identifying the needs is the first step and should start immediately. I told you in detail what assessing need means. Then there will be prioritizing the needs. So one patient can have multiple concerns. You as a counselor need to identify what is the priority, whether it is prevention, whether it is treatment, whether it is psychological support. It varies from patient to patient, and the counselor is the best judge for this. So, and I'm sure most of our counselors are doing that. Then plan. It is very important. Please make sure that you plan complete for ICTCs as well as for ART centers. Provide complete information regarding the facility, whether they are where they are referred as, like address, give contact details, give focal persons, give timings. We have, like, this is for ICTCs, like many a times patient coming after 5, after 6. This should not happen. Okay. Further, preparing client as to what to expect when they visit that particular facility. This is very important. You know, as being a employee of health system, being an employee of NACO, being an employee of HIV program, you know ki what kind of circumstances or what kind of persons or what kind of sitting arrangements or what kind of timing that patient is going to get where you are referring that particular patient. Please include all these information when you are referring. This is the actual post-test counseling for ICTCs to do. So this should all include, in addition to what actual things you are doing, this also should be a part of your referral. And similarly for ART, whenever you are referring that person to maybe RNTCP, CSC or OPD or anywhere else, please take some time to plan. And this is like this is, I have written it as key, this is skill of anticipatory guidance. So this is very important. Then facilitation. So facilitation means providing both information that most of us are doing as well as supports required by client to assess the services. It may be addressed, we have already discussed, but solution, like this is very important. Support includes identifying the barrier to linkage. In later part we'll discuss about barriers to linkages as well, but like it is counselor's job to identify what could be the barrier of linkage. Like some of you said ki miscoordination or gap of communication, etc. So all these things needs to be assessed and explore the solution on a case to case based manner. Like I'm sure you all are doing it. Like ICTC to patient said ki, well, okay, I got positive report but I cannot go next day, I have some function in my family, or any other, I have issues with my job and all these things. So all these you need to solve this on case to case based manner. And please try to wherever possible or wherever required, accompanied referral may be offered with help of like peers. It can be outreach workers, counselors themselves can do this, or any other health providers available in the vicinity can be used for this. So I think you don't anyone so I think there is a question from miscoordination कहाँ है, क्यों और किस तरह solve किया जाए. Miscoordination I meant with patient basically. Whatever you need to assess whether whatever counseling you are providing, how much of that patient is grasping, how much patient is understanding, and that does not apply to everyone. It is at few centers that may be an issue, but it is a common issue. It may because every patient does not have a similar understanding and similar IQ. You need to have an case to case basis counseling issues as well. So that is very important. If there is miscommunication, you need to clear it. Follow up and document, it is very important, and documentation is extremely important, because you just telling us ki patient reach there is not enough. You need to provide a documentation for that. So like at present we have referral slips, we have line list, we have linkage software, records and reports. So we have many mechanisms. At least follow some mechanism to ensure that all linkages are being captured well. Okay, so now since we have discussed the many of the referrals, can anyone enumerate what are the facilities under NACP? Are you aware of all the facilities that are present in the field under National AIDS Control Program? Or what are the other referrals that are required at ART center or ICTCs? Yes, TB, STI, OST, very good. STI, pipetacity, yes. Anything else? DAPQ, BSD, TI, CSC, very good. Anything else you want to add? I think many of you already know it. Just to enumerate, like facility integrated ICTCs. These are screening tests. Screening testing, these are doing screening tests. So they don't give positive reports, but they screen that patient with one test, and if found positive, they refer to IC. So these are the facility integrated ICTCs. Then standalone ICTCs, which provide confirmatory reports. Then there are STI clinics and Suraksha clinics. They provide syndromic treatment to STI clients. And what should be ART's role in reference to STI clinics? So that is, all patients presenting with STI symptoms can be referred or shall be referred to Suraksha clinics nearby your nearby center, and our medical officers should be aware of syndromic management of cases. For ICTC, there can be a two-way referral from ICTC to ART or from ART to ICTC that we are going to discuss. Then there can be facility integrated ART centers and ART centers. So these are basically the same thing. They provide all the care facilities. Then there can be centers of excellence. There can be ART plus centers, CSC. There can be opioid substitution therapy centers for IDUs or drug addicts. There are targeted intervention centers which work specifically for high risk group patients. So if you get HRGs, you please confirm whether that is registered with some targeted intervention center or not, and if not, you may refer. Yes, and then can be DAPQ. And what I am missing from this list? What are the facilities that are missing from these lists? At least ART should have, some of the ART should have questioned that, why that particular is not there, why I missed that. Anyone? What facility is missing from this list? Okay, TB, yes. Anything else? Blood bank, yes. Wow. So from ART centers, no, STI I have mentioned. Yes, Rajshekharan sir told it. It is Link ART center. Yeah. So no, Link ART centers and Link ART Plus centers are also facilities under NACP. They are ICTCs providing HIV care as well. So this is just in revision. I think all of you must know all the possible facilities in that may help PLHIVs. Okay, so this list of nearby facilities should be available at ART centers. Now, referral and linkages can be to HIV program for basically for diagnosis, or those who are already diagnosis for care and other purposes, can be within HIV program, like from diagnosis to care, from diagnosis to prevention, from care to diagnosis as well for family centric approach. It can be from HIV program to other. Okay, so there is a question. OST is opioid substitution therapy centers. These are centers, approximately some more than 100 centers we have, which are providing opioid substitution therapy for intravenous drug users. Okay, so from HIV program to others like TB, like OPDs of your center, like nutritional clinics to vaccination clinics, RMNCH plus, so there all other health facilities, or to social beneficiary schemes as well. So all these are referral and linkages. Okay, so we'll quickly discuss what are the key referral and linkages issues with our ART. So first is ICTC to ART. So it is very clear that all HIV positive detected at ICTC should be linked to HIV care, whether an LAC plus or a ART center for HIV management that has all things, counseling, CD4 testing, ART initiation, retention, everything. Okay, so the onus of this lies with ICTC. So it is very clear, referral role of ICTC is to ensure that referral and linkages. So it is not only referral, it is linkages. We always say ICTC to ART linkages. We never say ki ICTC ART referrals. You refer, and ICTCs has to ensure that patient get linked to that particular ART center. That is the very important, because we have at present we have linkages is around 82%. So still out of 100, only 80 or 85 patients are linked to ART center, and that is a very serious gap. So we all need to fill this up. Okay, so there is a triplicate referral slips which can be used. PLHIV shall be adequately counseled on the importance and benefit of getting registered with ART center. So that has to be done by ICTC. Again, for all ART center, like this highlighted is for you. The ART center staff has to ensure that they send detailed feedback of PLHIV who were referred to them from different ICTCs and have actually reached. This will help the ICTC staff to track patients. So it is not just yes, the onus is with ICTC. They will initiate the referral and linkages, but ART has to provide the feedback. You please, it is an emergency. Never do like this ki will provide you information after this month or after this or after 2 months or whatever, or email pe batayenge, whatever. That should not happen. This is very important. You design a mechanism, may it be a phone call, may it be a DAPQ meeting, may it be an email, whatever is working for you, but each ICTC should know what happened, whether the patient they have diagnosed reached to ART center or not, and this is very important job of ART. So data managers, counselors, you need to work as a team and provide the feedback to ICTCs. Okay, so this is the key message for ART center. So there can be monthly meetings and etc. for this. So this kind of triplicate form is there. I don't know how many states are filling this, but ideally there should be such kind of referral form. Upper part is filled with is to be filled by ICTC, and the lower part is for ART centers to be filled. So there are three parts. So one part remains with ICTC, one part goes to with patients, and one is couriered or either sent through email. And the this part has to be filled. This particular part has to be filled by ART center in these two, and this should go back to ICTC, and ICTC should go get all these information. And now this is again a very important and very untouched issue. What kind of referral can be there from ART to ICTC? That I want to know from ART centers. Yes, so yes, ART Motihari is saying send through via patient also. So one part is with patient, that comes through patients, and one part should come through courier. So now, yes, very good. Family testing, or to more precisely, spouse testing. Yes, what else? Partner testing, very good. So what else? One is family testing or partner testing. Anything else? EID, DBS, spouse testing, very good. And still something left. Child test, yes, that is EID. Yes, very good. Okay, so we'll see. So, okay, you have already enumerated this. Okay, so what is column number 3 of white card? Very good, you all know it. It is family details. So how many of you, now this question I need to get it from all the ART centers. How many you are regularly updating it? How many centers are regularly updating this family history part of white card? Okay, and whosoever will say yes will be checking those things, because whenever I go to ART center, this is only one time filled. Okay, so it is very, like, if that is like both spouses are positive, it is updated once, it is good. But if the spouse is negative, then it cannot be filled one, it has to be updated. Okay, so please look into it. The family part should be updated regularly, and it is good if you most of you are doing it. It is excellent efforts. So have a family centric approach. Always tend to, so it is request to medical officers and counselors, tend to see the family part of white card in every visit. See if spouse is tested or not, and that too regularly. It is not once. Okay. See if children are tested or not, at least once. Okay, sorry, we had some connectivity issues, but I think now you will be able to hear it again. Okay, so we'll move to next part, that is ART RNTCP. So all patients, this is just to reiterate, all patients should be screened for TB symptom complex. What is TB symptom complex? Please tell me. What is TB symptom complex? What is to be seen by care coordinator, counselor, staff nurse, and what are those 4 questions which you will ask? Very good. Weight loss. No, it is not 10 point, but I am asking for TB symptom complex. Weight loss is 1. Yes, cough, night sweating, fever. Very good, Kasargod. Okay. So cough of any duration, fever, weight loss, night sweats, and in case if there is children, it will be contact of TB. So if any of the answer is yes, you need to refer that patient to appropriate investigation. Medical officer has to look into overall picture, not just 4 symptoms, but see lymphadenopathy, see neck rigidity, everything you have to see. Okay, staff nurse to coordinate and follow up for the results and test. So this is very important part on this is very important in part of staff nurses. Please follow up for results. Okay, it should not be blank, and I have seen many line lists to be blank for follow-up test. If TB is diagnosis, then should be referred to RNTCP. and staff nurse to coordinate and follow up for ATT, CPT and ART initiation. This is in HIV TB register. You have to see all patients should receive ATT, should receive CPT and should receive ART. This is staff nurse primary job to ensure all these linkages, and HIV TB line list should be shared with STS, and HIV TB register is there. You all know, and these are referral formats. So I'm sure you are aware of it, and so I'm not going in detail. So there is this part to be filled by nurse and this part to be filled by STS. In case any of the center is not aware of these formats, please write to your joint director or regional coordinator or to me. Will try to explain it to you. Okay, so this is line list SOP. ART center prepares TB symptom screening happens. Then there is a line list of symptomatics. ART nurse fills columns 1 to 10. Nurse shares line list with STS on day 1 of next month. STS to complete column 11 to 14. STS returns completed line list at the end of the month to nurse, and nurse prepares monthly report, and this also forms a basis of HIV TB register. So there is one question. Some centers are sending sputum for CBNet and those eligible patients receive ATT from ART center. Yes, just that is a limited project for only 30 sites. That will be eventually rolled out, but at present this is the mechanism what I am showing you. But yes, daily ATT will eventually be rolled out. At present only 30 centers are, so I don't want to confuse all other ART centers at present. And yes, what Dr. DJ is saying, that staff nurse must attend a monthly coordination meeting of RNTCP regularly. It is very important to ensure to improve referral and linkages. Okay, this is TB HIV register. I'm not mentioning it detail. ART referral form, you all aware. And now what is this? This is transfer out form. And yes, it is also a referral and linkages. You refer patient to another center or you transfer out patient to another center and you don't confirm it. You don't confirm the linkages. That is a serious problem. I request all the ART centers and all the counselors to do that. Till the time you don't get an confirmation of registration of that particular patient in another center, that patient should be considered as missed and eventually lost to follow-up. Till that, now this functionality is in IMS, inventory management system. Please use that and see. Now you can see how many of your patients are transferred out but not reached to other ART center. Please start following up those patients. It is a very serious gap in our program, it may be. So yes, now next question, or maybe last 1 or 2 slides. What are the barriers to linkages? Yes, so DJ is saying correctly, IMS2 is used by all ART center and it is must that all dispensation and all transferred out happens through IMS. Yes, so Sita Medi is again telling the same thing. Yes, many of the centers are not using IMS, please, so it is a message to all those centers who are not using, please start using IMS, but that is not pertaining to this. We'll continue to our topic today. What are the barriers? Yes, barriers to linkages, very good. Communication gap with between staff, yes. Then there can be ignorance, yes, it can be. What else? So you're not telling me the common answers I hear from ART center. Problem with migrant population, very good, yes. Yes, distance, yes, very good. PCOE Kolkata, it is distance is a common. Financial issue, counseling, there can be many. Okay, so okay, sorry, I just missed this part. Again, we will discuss in brief referrals to CSCs. So you all know what all patients you need to send to CSCs. There should be regular sharing of data as well, and I wanted to show you this this list. Okay, so this is the list of all that kind of patient that you can share with CSC. Now I want to know from you which are the priority. I intentionally not arrange this priority wise. This is randomly arranged list. So what is the priority? What should be, which of these patients should be referred to CSCs for linking back, or should be given to CSCs? So out of these list, what is in front of it? Okay, starts from baseline CD4. No. What is the priority? Yes, somewhat very good, Rohtak. LFUs and eligible for ART, yes, eligible but not initiated, pre-ART LFU, LFU. So your priority will be on ART miss, on ART LFU. On ART LFU, that too of recent cases. A clear message has been gone, a letter signed by DDG has been sent to all ART centers stating that you give priority to immediate LFU. Those LFUs of recent years should be given priority. It is not that you won't track others, but the priority is clear. It is miss, recent on ART LFUs, and eligible but not initiated on ART. Then again, then pre-ART LFUs, baseline CD4 not done, all these things come. So you need to have a clarity on. So this OM has been gone from DDG CST. I request all ART centered medical officers to go through it. And I'm sure your tracker sheet sharing also, all ART centers have to update master line list of all enrolled patients every month based on feedback received from previous month's line list shared with this. You need to keep every month master line list in a separate month-wise folder in soft copy, so that you know. And standard tracker sheet should be shared in separate sheets for district-wise, state-wise LFU miss with local CSC, so that they can have clear identification, or clear demarcation of, they can do the outreach clearly. And PM have to report to CST in charge directly in last week of every month. So this all information you already have. Yes, so we were discussing about key barriers. So these can be, so there are few questions. I'll again send coordination with must be strengthened. Yes, absolutely, I agree with Dr. DJ. Coordination with CSC must be strengthened, and monthly coordination meeting with CSC is must. And whatever CSC are reporting, it is responsibility of ART to give them feedback. If they are saying that this patient came back, you have to confirm it that that patient came back or not. So that coordination has to be there. There was one more question. Please share all ART national level address center. So the national directory of ART center is on NACO's website. You can download it from there, or if you not, we will circulate it again. But it is there on the NACO's website. So this is barriers for linkages, lack of understanding of importance and requirement of services. So please ensure that patient, you need to make patient understand ki why you are referring. It is many times patient will say ki why you are referring me to that center, why you are now, I came that those fellow told me ki go there and you will get treatment, and now you are telling me ki I should go to some other place as well. So try to explain that patient ki why that particular service is required. That is very important. And lack of confidence on report, maybe their fear of discrimination, distances, lack of information, lack of client friendly environment, long waiting hours, financial constraints, lack of caregivers. So most of it or many of it can be done, can be dealt with by good and regular and effective counseling. So our counselors needs to spend more time on such patients who need referral, patients who are coming from somewhere else or who are being referred to your center, or you are sending patient to somewhere else. Those needs much time. Please follow that assess, prioritize, plan, assist, all those things with the patient. Then like distances, long waiting time, financial constraints, you can use the services. We have so many Link ART centers, we have Link ART Plus centers, we have so many ART centers, we have care and support centers. We can link them to social protection schemes for whatever financial aid they can get. So all these needs to be that but basically it is assess the need. So there are solutions for all these things, but you need to invest your time in assessing needs and prioritizing needs and referring that patients and linking that patients. And it is very important that all possible solutions or measures should be made to identify issues and explore solution to these barriers on case to case. Again, case to case basis is very important. You cannot have a standard guideline or cannot have a standard questionnaire or cannot have a standard checklist which can be workable across all population of patients. You are the counselors, you are the healthcare staff providers of ART centers, you are the best judge to identify the particular situation of that patient. Yes, so there are other issues, mental illness, homelessness, substance use and immigrants. There are lots of issues. So like patients who need financial help might be rare case, but please guide. So the best possible answer is linked to some or the other social beneficiary schemes. Like there are so many social beneficiary schemes available in, so now NACO has launched a website also where you can just write age and age, gender and state, and you will get to know what all social beneficiary schemes are available in that particular center, and this way you can do. So I'm sure you won't be able to provide money from ART center, but you can link or you can refer that patient and link that patient to the center which can help this way. So that is the only solution to this at present. Yes, so as Telangana is saying, there is 1,000 rupees pensions, and many other states are also providing this. So now this is the end of my session. Thank you very much for listening, for being patient. But I just have a one request to all ART center. Please share best practices or innovative ideas to improving linkage across retention cascade. If you have done something, if you have some ideas that can be utilized efficiently across this station, across the nation, please write to me at bamrotiya.manish@gmail.com or your RC or your JD, so that we can have this thing, we can make some use of it. Thank you very much for attending this session. I hope you found this helpful, and do write to me in case you have any issues. Thank you.
Thank you so much, Dr. Bamrotiya. Thank you for the most valuable session. I'm requesting all the participants to kindly enter their e-poll displayed on the screen. It's just only 5 questions. It helps us to improve our quality of the sessions. So I'm requesting all the participants once again to kindly enter the e-poll displayed on the screen. If any questions are unanswered, those questions will be answered through email while sharing the recorded link. And thank you all the participants for participating for this wonderful session. Thank you so much.